right. Good morning, good afternoon, and good evening to everyone joining us today. My name is Natalie Mistry, and I am a project and policy coordinator here at the International Federation on Aging. And I will be moderating today's webinar, which is named Mapping Shingles Vaccination to Improve Advocacy Efforts and Uptake, launch of the Shingles Atlas. Together, we will be getting an in-depth look at shingles disease, shingles vaccination, and shingles advocacy and policy to better understand how to influence vaccination policy changes at national levels across the world. Just before we begin, I want to quickly get some housekeeping out of the way. We would like to remind you to please keep your microphones muted during the webinar. For the question and answer and moderated discussion portions of the session, you may pose questions and comments either in the chat box, or you may raise your hand and we'll give you the opportunity to pose your question. Feel free to keep your videos on during the session. The session will also be recorded for note-taking purposes and may also be posted on the IFA's Vaccines for Life or V4L platform. And so I would now like to briefly go over the agenda. After I complete these welcome remarks, I will hand the floor over to Dr. Pratik Lala, who will be setting the scene on shingles and shingles vaccine in older adults. Dr. Lala's presentation will be followed by Ms. Lucy Buccis, who will take us through advocacy strategies to support comprehensive vaccination policy. I will then present on the IFA's newest advocacy tool, the Shingles Atlas for Adult Vaccination, or SAAV. We will have the opportunity for a brief question and answer period, followed by a moderated discussion, and then some closing remarks. So we have got quite the packed session today, so we will get started now. Dr. Lala, I would like to now invite you to start your presentation.
Thank you very kindly. I'm just going to start sharing my screen here. Thank you all for having me today. It's a pleasure to speak to you on this topic. It's certainly an interest of mine for a variety of different reasons, which we will get to. Okay.
Yep, we're good to go.
Perfect. Thank you very much. So I'm going to speak to you briefly today about the actual disease and potential therapies and preventive measures for shingles. So let's get into it. And as many physicians are wont to do, I'll start with a case because it's a useful way to give you a picture into what real life looks like in the case of certain disease processes. So this is a case from December of 2020, as you might imagine, sort of in the heart of the pandemic. And we'll look at the case of a 76-year-old woman who is 1 week after recovering from COVID, presenting to hospital with a 2-day history of headache and vomiting, which are both concerning symptoms in an older person, in anyone really. When she comes in, she's mildly disoriented and somewhat lethargic, and her neuro exam is abnormal in a number of ways, including this ongoing headache, as well as some light sensitivity and other changes. Her blood work, when it's taken, reveals a low sodium level, and a brain CT scan that was done at the time demonstrates some changes that are suggestive of some kind of encephalitic process. She's therefore admitted to the neurology ward for treatment and further investigations. And over the next few days, she develops this blistering rash over the left side of her forehead and scalp, which also involves her left eye. So one of the tests that was done was a lumbar puncture or spinal tap, and testing of the spinal fluid confirms a diagnosis of VZV encephalitis. So let's pause the case study there. We'll come back to it toward the end, but let's think about what exactly is VZV to begin with. And to understand that, we need to look a little bit at viral biology. Some of you may know after the pandemic, and we're all virologists and epidemiologists now, but the viruses can come in different flavors. Some of them have a genome that is based in DNA. So those include things like adenoviruses, which cause colds, HPV, smallpox, herpes viruses, while others have an RNA genome, including the virus that causes COVID, as well as influenza, Ebola, and other things like that. If we drill down on the DNA viruses, one of the families that I mentioned are the herpes viruses. There are over 130 known species, 9 of which are known to cause disease in humans, the human herpes viruses, or HHVs. If we break those down further, the first couple there are the herpes simplex viruses 1 and 2. You're familiar with those as causing cold sores and sores in the genitalia. Epstein-Barr virus causes infectious mononucleosis, a few different kinds of cancers, and intriguingly, potentially even multiple sclerosis. CMV, where most of us are infected with it, but it usually doesn't cause problems unless we become immunocompromised. But what we're really interested in today is VZV, and that's varicella zoster virus, which is the causal agent of both chickenpox and shingles. This simplified diagram gives you a bit of a breakdown as to what the virus particle looks like. It's basically a DNA genome in the middle that's encapsulated in a protein capsid. And then there's a lipid envelope with some surface proteins. And those surface proteins become important in the development of vaccines. I don't expect you to see or be able to read all of this, but I'm just going to focus on a few different things as to how the VZV life cycle works. Many of us of a certain age, my particular age, when we were young kids, this was before the age of chickenpox vaccines. So we experienced what it was like to have chickenpox. My sister very kindly gave it to me. I kindly gave it to others. But essentially, this virus is transmitted through the respiratory route, and usually in young kids, it infects the tonsils and other mucosal lymphoid tissue. From there, it's picked up by certain immune cells and thereby disseminates to other areas of the body, including the skin. From the skin, it causes these blistering rashes that we're all familiar with chickenpox, but it also goes from the skin into the peripheral nerves. And when that happens, the virus travels up the length of the nerve into the spinal cord, and it can infect what's called the dorsal root ganglion, or DRG. And in that instance, it can sit there and lie dormant for years to decades before potentially reactivating in times of stress or times of immunocompromise, when that latent virus reactivates itself and comes back down that nerve axon and causes shingles, which is the secondary kind of infection with VZV. And it's what we're interested in talking about today. Because of the way the nervous system works and the way that it's organized in its layout, these peripheral nerves innervate the skin in very distinct regions called dermatomes. And this is why when you have shingles, it usually appears as kind of a stripe around one half of your body, because those viruses travel down that nerve route into the peripheral nervous system, but specifically to these dermatomes on the surface of the body. And so what you'll see when someone has this shingles reactivation is they start off with this prodrome, this generalized unwellness, where you have symptoms like fatigue, headache, sensitivity to light. Later on, it can cause other problems generally with certain organ involvement as well. But following that, you have this tingling, itching, or burning kind of pain, usually in that dermatome region, that strip of skin around your body, which then develops into this blistering rash that we're familiar with. That rash can last for several weeks, after which it tends to resolve, but somewhere around 15% of adults who get shingles persist in this state called post-herpetic neuralgia, which is this burning pain sensation that can last for months on end. And the difficulty there is that controlling that pain can be very challenging, even with very powerful medications. So that's kind of where we're at with the disease of shingles. When we talk, there are only a couple of things to do about shingles. One is the pain control. Second, there are a couple of drugs that can help when you already have shingles to shorten the duration of the illness. But really, the best way to handle it is to prevent it from happening in the first place. And the way to do that is with vaccines. Vaccines, as you know, come in all kinds of different flavors, different platforms, different kinds of vaccines. Way back in the late 1700s, when Edward Jenner developed the first smallpox vaccines, what he was using then was what's called a live attenuated virus. So the virus is still alive, but it's been weakened to a degree that it can't cause the disease, while still being able to stimulate the immune system to develop a reaction in case the immune system sees that virus later on. And so along the years, over the next couple of centuries, there have been a number of different developments in how different kinds of vaccines have been developed. 1970, you'll see that protein subunit vaccines were developed. And if you recall back to the picture of the varicella zoster virus, those surface proteins, we realized that we can take genetically created versions of those surface proteins and introduce those as vaccines to the body to allow the immune system to recognize those proteins and then develop reactions against them in case they ever see that virus again. From that standpoint, in 1988, the chickenpox vaccine was developed and has now become part of the standard childhood vaccination schedule. In 2006, a similar live attenuated vaccine or live zoster virus, LZV, was developed in 2006. And 2017, a subunit vaccine or a recombinant zoster vaccine, RZV, was developed as well. Now, why is this important to have these kinds of vaccines? Something to understand is that somewhere around a third of Canadians will develop zoster within their lifetime, and the incidence and severity of both shingles and the post-herpetic neuralgia, this pain syndrome, increases greatly after 50 years of age. So that's where we're at in terms of shingles vaccines in the context of the elderly. Not that 50 is elderly, because I just turned 50 myself. So let's try and decide what we mean by that. If we look at these two different vaccines, the live virus and the recombinant separately, the live virus vaccine was developed by Merck and approved in the US in 2006, whereas this recombinant vaccine was developed a bit later by GlaxoSmithKline and approved by the US FDA in 2017. In the first case, the live vaccine is a subcutaneous injection, so it just injected under the skin, or it can be injected into a muscle like the deltoid in the shoulder. And the nice thing about it is that it's a single dose vaccine. That's good in terms of having patients come in just the one time. They don't have to come back for a second shot. So logistically, it becomes a bit easier. Whereas the Shingrix recombinant vaccine is a two-dose vaccine that's given 2 to 6 months apart. Now, the challenge was which one of these is better. And so these trials were done, and what was understood is that the recombinant vaccine, Shingrix, had significantly better rates of efficacy for preventing herpes zoster, 97% efficacy, whereas the Zostavax live vaccine had only a 51% efficacy in older adults. And also the Shingrix vaccine had about a 90% efficacy in preventing post-herpetic neuralgia in adults over 70 years of age. Due to those numbers and the fact that the live vaccine can't be given to immunocompromised people because it's a live virus, it was discontinued pretty much all around the world between 2018 and 2023. And as far as I've been able to find, the Zostavax vaccine is no longer available. It's no longer being manufactured by Merck. So what are the current recommendations for the recombinant zoster vaccine? Many developed countries worldwide have recommended the use of this vaccine for individuals over the age of 50 who don't have other contraindications, or individuals who are over 18 years of age who are at increased risk because they're immunocompromised in some way, either due to disease or drugs or age. Having said that, a lot of countries don't have any recommendations for population-level zoster vaccination, including countries like Argentina and Brazil and others. And I'm sure we'll get into some of that when we discuss the Shingles Atlas. The other piece is that different jurisdictions around the world have varying levels of public funding available for zoster immunization, even differences within countries. So for example, in Canada, where the out-of-pocket cost for the recombinant vaccine is about $300 for 2 doses. In Ontario, for example, where I am, it's covered for only people between the ages of 65 to 70 years. Whereas in PEI, it's covered for everyone over the age of 60. But most provinces and territories actually have no coverage, public funding for this whatsoever. So there's quite a bit of variation even within the context of a country. There are many factors that can change the effectiveness of vaccines. Some of these are to do with the host, in other words, the patient, things like older age, immune compromise, underlying health conditions. I'm not going to go through this slide too much further. You can look at this afterward. But there are a number of different barriers to vaccine uptake as well, which we'll get into in the question and answer session. I just wanted to finish off by getting back to the case, just to finish it off. This 76-year-old lady, after 3 months of hospitalization and rehab, regained reasonably good function, but she continued to have significant postherpetic neuralgia on the left side of her face and scalp for many months. Fortunately, it developed over time, and now she's able to ambulate with a walker, perform many activities of daily living, and she looks forward to moving into a new condo with her husband very soon. And the reason I know these things is because this is my mom, and she had to go through this process. So I have very personal reasons for talking to you about this today. So thank you very much for your time. Appreciate it.
Thank you so much for that presentation, Dr. Lala. You know, we get to learn a little bit more about shingles itself, how it presents, especially with those painful symptoms and what we can do to kind of help prevent it with vaccination itself. Having this awareness truly allows us to have a deeper understanding and what we can do also at a public health level to kind of prevent it, and what we can do with others around us to kind of talk to them and see what we can help them with as well. Thank you so much. All right, so now I would like to invite Miss Bucci to start your presentation.
So I want to say thank you very much and extend some gratitude to the IFA team for inviting me to talk about advocacy with regards to shingles vaccination policy. I also want to briefly state that Bucci Hepworth Health Services is located on the Haudenosaunee lands and recognized as the ancestral location for exchange of Indigenous nations. So I don't have any major conflicts of interest, except to say that my work, the bulk of my work, is funded by the University of Toronto, the Public Health Association of British Columbia, and the World Health Organization. So what I'm going to talk to get today is pick up where Dr. Lala graciously left off with regards to the barriers to shingles vaccination, but I'm going to look at it from a different perspective, and that's from advocacy strategies. And I think it's safe to say that advocacy has come a long way over the last 2 or 3 decades. In fact, many of the major components of advocacy include awareness building, education, and communication. And they form part of many different types of models, which are top-down, bottom-up, and sometimes horizontal. And so I want to talk about a different component that should be included and is probably included in many of these different models, and that's data collection and analysis. And I think the case presentation that Dr. Lala just gave really informs what we should be doing when it comes to advocacy and advocacy work. So I just want to start again with the data, and the big component to this, and I find when I work with a lot of coalitions and consortiums, is that the data they collect could be homogeneous rather than heterogeneous. And so what I try to do is encourage them to look at different knowledge syntheses and systematic reviews to get more information about the policy change that they're looking to achieve. In this case, this slide really tackles a recent report by Statistics Canada, which looked at Canadian health surveys on seniors between 2019 and 2020. And two of the data sets were collected asking seniors questions, seniors living in the community, asking questions about pneumococcal and shingles vaccination. And what they found was an estimated at 36% of Canadians in that population had actually received the shingles vaccine. Now that data might have changed since then, but what they interestingly also found is that there are some socioeconomic barriers to shingles vaccination, in particularly your status in Canada. So if you're an immigrant, you're less likely to have been vaccinated against shingles. if you're a resident of rural and small populations, if you have lower household education and income, and if you have fewer regular visits with the healthcare provider, and especially low perceived health. In addition, this survey work and knowledge synthesis found that there are several vaccine hesitancy issues. Now, some of these you might recognize already, so I won't go through all of them. But in essence, the big components are cost, fear and discomfort, unsure of benefits, don't think that vaccination against shingles is necessary. So people don't think they're at risk, and that's a reoccurring theme, and really not getting around to it. And a lot of these vaccine hesitancy factors are found in other surveys done elsewhere. So what other sources of data do we have to look at when we're doing advocacy work? And the big component of that is vaccine policy. So what is the status of policy for shingles in Canada? And Dr. Lala talked a bit about the programs already. So I'm going to look at it from a federal level and then a PT level, a provincial territorial level. So nationally, the National Advisory Committee on Immunization and the Canadian Immunization Guide both recommend that adults 50 years of age and older receive RZV. There are other sub-recommendations, as Dr. Lala mentioned, with regards to your health status and also where you fit in as different populations. I won't go into those right away. What I want to note is these recommendations are also being updated to include more details on the age group from 18 and older. So expect that to change very soon. Additionally, at the national level, I want to say a couple of things about the National Immunization Strategy objectives. Currently, we have objectives for coverage in a 65 plus population for influenza and pneumococcal, but we do not have for shingles. So I wanted to bring that up. The important piece here is that a lot of the components under the NIS actually support shingles vaccination, including data collection, addressing key barriers and best practices, and improving immunization coverage. So a lot of these components are important within the policy structure at the federal level that could be used for advocacy for shingles vaccination. Now, the interesting thing is that VZV, as it presents as chickenpox, is a notifiable disease at the federal level. And that is monitored through impact. I know that we're going through a bit of restructuring there because of funding, but as long as I can remember, it's still the case. And that's for children. There is no consistent or systematic monitoring and notifying of shingles at all levels in Canada. So this is an interesting policy initiative that could be of interest to some advocacy groups in the future. But I just wanted to bring it up because at the federal level, there is no policy for this. Provincially, I think Dr. Lala mentioned this, there are actually 4 jurisdictions that are currently offering herpes zoster shingles. This is taken from the Public Health Agency of FACTS website. It was updated 2024, and it's usually data that comes from the CNCI, which is the Canadian Nursing Coalition for Immunization. So they usually update this, and you can see that, and to Dr. Lala's point, you can see that the age range with regards to the policies and programs are extremely diverse across across these 4 jurisdictions, and the fact that the other remaining jurisdictions do not have policies is problematic. So now that we have some of this data and intel, how do we use it for advocacy strategies to change shingles policy in this country? As we all know, advocacy has several actors, and that's across the board in the health sector. Civil society, healthcare providers play a huge role, NGOs, academic institutions, professional and patient-centered organizations. And I work with and have a lot of experience with consortiums and coalitions, and we do this through bringing awareness. And of course, the policy target group are policymakers. So how do we get all this data, all the information, all the education, the messaging, the communication to reach the target group? Civil society and healthcare providers are really good at raising awareness. They do it in many different ways, including repackaging scientific data and knowledge through storytelling, as you just saw with Dr. Lala's example case story, which was excellent, by the way. And healthcare providers are really keen and have a pride when it comes to making healthcare and health prevention recommendations. And that has not changed. On the flip side of this, NGOs and larger, patient-centered organizations, professional health organizations, do on different scales data and evidence collection, reports. They do a lot of peer-to-peer education. They're very mindful about their target audiences, particularly on social media, which is now changing the way we're exchanging information. But they all do this at different capacities and at different levels. So why does this matter? Well, because when we collect all this data and put them in nice reports, or we do a lot of advocacy work, we do media relations and communications, all of this kind of gets blocked at the knowledge translation component. And so what happens is we may have a great fact sheet, but the evidence never gets to the target audience of policymakers. And so there are different ways that we can look at advocacy through evidence-based interventions that can help with this. Some of these interventions include pamphlets, letters, and brochures when they're done in conjunction with other pieces such as policy briefs and recommendations, editorials, media public relations. Now, there's some organizations that would like to do one or two together, but the evidence shows the more you do, the better the strategy for advocacy will achieve the outcomes that you're looking for. One of those pieces happens to be the evidence to decision framework, which is an important tool for building the evidence to include into these interventions. So when I work with coalitions and consortiums, there's a tendency to tackle many different policy areas within an advocacy campaign or work. As much as a lot of the issues, especially the barriers in vaccination, overlap, especially in vaccine hesitancy, most of the smaller organizations tend to focus on one policy issue at a time for capacity reasons. But if you can do more, so for example, tackling herpes zoster with or shingles vaccinations with pneumococcal vaccinations because you're targeting the same population, that's a great way of doing it as well. So some of the areas that I see from the data that I presented to you this morning include access to vaccines, public knowledge, attitudes, and beliefs. Equity is a clear example where there are policy issues in this country. Logistics, so do we have enough inventory of vaccines to meet the demand? Immunization coverage, there are several data gaps, as I mentioned, and professional training, there's always room to improve access to education. So what are some of the key takeaways when it comes to advocacy? Quality data collection and analysis is always important. So preparing those knowledge synthesis pieces, and there are many tools and frameworks available to be able to do this in a very concise way. But obviously, if you're trying to communicate a specific message, especially when it comes to shingles vaccination, you want to be able to package that in a way that it will get the attention that you're looking to achieve. And of course, it helps to produce better results. So lastly, evidence-based communications must be coordinated. So once you've packaged all of this, how do you strategize to communicate? Whether that's social media, whether it's media relations, all of that needs to come together in a very effective way. So thank you very much, and I'll pass it back to Mitali.
Thank you so much for that presentation. It really provided us with a better idea on how exactly we can harness different strategies in advocating for vaccination policy changes while working towards improving public and professional awareness through better communication and better education as well. Okay, and so this segues quite nicely into my presentation where I provide an example of this type of advocacy tool to support vaccination policy with the Shingles Atlas for Adult Vaccination, or SAAV. And so with this part of our session, I would like to discuss the purpose of the SAAV by addressing the urgency behind it, its utility as an advocacy tool, and how exactly it can be used. So around 30% of people globally will experience shingles and the associated side effects throughout their life, with most of these cases being in or amongst older adults. And to assess the status of shingles vaccination policy across Europe, the IFA conducted a study titled Influencing Action on Shingles Vaccination Policy, which highlights gaps and informs a call to action on the importance in improving awareness of vaccine preventable diseases such as shingles. So the study itself used both systematic reviews and expert interviews, and it looked at whether there is an established national immunization technical advisory group, also known as NITAG, shingles vaccine recommendations across age groups, funding, vaccination coverage rates, processes for monitoring vaccination coverage, and pathways to receiving shingles vaccination. And so findings from the study were consistent throughout both the environmental scans and the expert interviews, highlighting a lack of consistent policies around adult shingles immunization across Europe. And largest gap that you can see over here was found to be in the lack of comprehensive government funding for shingles vaccination in older adults. 43% of countries did not have a federal recommendation for shingles vaccination for older adults. 50% did not include shingles within the national immunization schedule, and 71% did not provide comprehensive funding to all older adults to cover the costs of receiving shingles vaccination. So this brings us to some key points of urgency. So there is an unprecedented number of individuals at risk of serious complications from vaccine preventable diseases, which means there is a pressing need to prioritize not only the implementation of NITAG recommendations, but also associated funding of these recommendations. There remains a disconnect between the knowledge created by researchers and the understanding of the public and policymakers around shingles vaccination, disease burden, and the risks associated with that. And disease control itself can help eliminate the downstream burdens of disease and vaccination costs. It can also strengthen health systems and reduce health inequity. And given the substantial socioeconomic burden of shingles amongst older adults and its grave impact on their overall well-being, there is an urgent and crucial need to prioritize shingles vaccination policy to ensure healthy aging for current and future generations of older people. There are still some very fundamental barriers to shingles vaccine uptake right now, including lack of awareness of the consequences of shingles and the lack of government investment in shingles vaccination. And because of this urgency and startling lack of comprehensive vaccination policy for shingles, there was a need to bridge the gap in understanding where countries, not only in Europe, but across the globe, can make improvements in their policies to ensure that more adults are receiving this vaccination. And so the overarching goal of the SAAV is to essentially improve the awareness of shingles vaccination and to increase uptake rates for adults around the world. And the SAAV provides up-to-date and easily accessible information and data on country-specific shingles vaccination. So the SAAV will house information and data across 8 main categories, which include national vaccine recommendations process, shingles vaccine recommendations and schedules, adult shingles vaccine funding, vaccine coverage rates, monitoring mechanisms for vaccination coverage, prevalence rate on burden of shingles, shingles vaccination pathways, and barriers to shingles vaccination itself. The IFA's Vaccines for Life, or V4L platform, will house the SAAV and will be in the form of an interactive world map. Users are directed to instructions to use the Atlas on the main page to ensure ease of access to the information. And it's available for your desktop as well as your mobile or tablet, any kind of such device. And the Atlas itself is quite user-friendly. It'll allow policymakers, researchers, decision makers, and key stakeholders to navigate quite easily between the 8 categories across the map. And in order to use the map, the user can click on the category of their choice. In this case, we have National Vaccine Recommendations process selected. And then the user may click on the country of interest. In this case, we clicked on Mexico over here. And once the user clicks on the country itself, a dialog box will present the user with a summary or a bite-sized piece of information on that country for that chosen category. And in order to read more on that topic, the user is able to click on the button below in this dialog box called Download the Report. And by clicking on this box, will allow you to download a PDF that will not only provide you with more information on that category for that country, but it will also provide you with information and data across all of the 8 categories for that country itself. And here you can see a snapshot of one of the country reports that is available for download, in this case for Mexico. So here we can see the National Vaccine Recommendations Process category available. But if you were to open the full report and to scroll down further along, you would get all of the category information for that country, as well as information on the other categories. And so there will be cases where countries and their government websites will not have information or data available on specific categories or on shingles vaccination at all. And this will also be noted in the atlas itself. And in those cases, the lack of information is very telling of the gaps that do exist, and the need for policies to urgently be addressed in those cases. So the SAAV aims to be a source of the latest evidence on the status of shingles across the world. To ensure that the SAAV has up-to-date country-specific knowledge, there will be continued assessment of new evidence, as well as optimization of the platform itself following its launch, as users are using it a lot more and providing us with feedback as well. And so the atlas itself will be a large repository of data on the status of shingles vaccination at the country level. This tool will help provide evidence to influence and shape policy, depending on where data or information points towards for a given country, and where there can be areas of improvement in these different categories. Decision and policymakers can easily acquire this knowledge and use it to implement strategies towards vaccination policy changes for shingles vaccination. So now we have, I will say about 5 minutes or so, just to kind of answer any immediate questions. Questions are open to Dr. Lala, Ms. Bucci, and to myself. And then after any questions, we'll move on to the moderated discussion period of this session. Just as a reminder, if you have any questions, please place them in the chat itself, and then we can go from there. All right. I believe we have a question from Shmuel. It's addressed to Lucy. So if Lucy can kind of answer it first, and Dr. Lala, if you have a take on it as well, I'll just read the question to you, Lucy, for ease of access. So what, according to you, are the barriers to shingle vaccination with older adults from perhaps lower socioeconomic status, different populations such as that? And then according to you, what might be the role of authorities in that situation to improve accessibility for older adults to the shingles vaccination?
Okay, so there are many perspectives, and you're right. So Dr. Lala might want to chime in as well. I would say, so speaking from public health perspective, the biggest barriers for lower income is obviously cost of vaccines in the provinces where there isn't equitable access. And secondly, cost to be able to get to your appointment. That's always been an issue for 65 plus who are living in the community, but not as mobile as some other independent individuals. So those are, I would say, is always the top two. The third would be inventory and access to the vaccine. We've seen this with flu before, where there's just not enough to go around. So I would say those from public health, those are the issues that are probably at the top. What could we do to remedy some of these solutions? There's quite a few interventions that are evidence-based that have shown to work, and some not as good. Some of those interventions include being able to subsidize bus tickets, making inventory a little bit more transparent to people. So using online booking solutions. However, there's always a learning curve with those. And we saw that with COVID. So there's pros and cons to that. Obviously, lowering cost is always is an issue in making vaccines available in all jurisdictions. But when you're looking at universal programs, that's a tricky area. So yeah, I'll stop there and I'll let Dr. Lella talk about some of the healthcare provider perspectives on this. Thanks.
Sure. Thanks, Lucy. Just to clarify, the barriers to shingles vaccination in the elderly and certainly in low socioeconomic status populations are not unique to shingles vaccinations. These are across the board in terms of almost all healthcare access. And so the kinds of interventions that Lucy was talking about can apply across the board. In some of the more recent studies that have been done specifically on the topic of access of shingles vaccines for older adults, as she mentioned, cost is the number one factor in Black and Indigenous populations, for example, in the United States, and barriers to not just out-of-pocket costs for the vaccines, but also out-of-pocket costs, as she mentioned, about travel to the healthcare professionals, et cetera. Couple of things to mention. One is that, nowadays there may also be opportunities for people other than physicians to be providing vaccines. As we know now, pharmacists are capable of giving certain vaccines to patients. There are some limitations around that because of potential immediate side effects to vaccines to be aware of. But, the same kinds of problems exist for many other reasons. The other piece to mention is that, the science, we have a pretty good handle on the evidence for why the elderly in particular should get vaccinated for shingles. The problem is that when it comes to policy making, science is not the only factor that goes into that. There are many other considerations that go into policy. And so some of those barriers need to be addressed as well, not by healthcare professionals, not at least not alone, but by other people in the community as well.
Yeah, thank you both for your answers. It's good to have all those perspectives, because at the end of the day, if we are trying to solve all these issues, we do need to work together, combine all of our knowledge realms, and really figure out the best way to go about it, and not to forget kind of any of the important pieces. All right. And we have a question here from Katrina that's can be addressed to either one of you. Do either of the speakers have any advice on making this vaccine more accessible in more low resource settings within and outside of Canada? For example, making the case for inclusion in national or provincial immunization programs.
Yeah, so this is not so that different from the first question, but what I want to say is what we've seen, and if we look at previous examples, and COVID is probably the most fresh in everyone's mind, some of the solutions have been very much community-based, okay? And some organizations, for-profit organizations, have lent a hand through different initiatives. So, providing vaccines in the workforce. So as we extend the retirement age, unfortunately, a lot of people are either going back to work at 65 or staying in their job for a lot longer. So workplaces have been some interesting ways to deliver and administer vaccines. That raises issues, however, that Dr. Lala mentioned. The other piece is to look at mobile solutions. So caravans have worked for COVID. But again, those also present different issues. Drive-throughs have been successful in a lot of hospital settings when it comes to vaccinations for flu. So there are different types of solutions there that could be helpful. And they could be used not just in Canada, they could be used elsewhere as well. So as long as you have access to some of those resources, some of them more heavy intensive than others. But I'll stop there because I know Dr. Lala has other things to add to this.
Sure. Thanks, Lucy. The only other thing I'd add is that from a technical standpoint, the vaccine does require certain logistical things to happen. So there has to be a cold chain, for example. It has to be refrigerated for some period of time before being given to a patient. And in developing countries, in tropical countries, that can be a challenge, as we've seen with other vaccines as well. Um, and even in Canada, in remote communities that don't have ready access to healthcare professionals, getting the supply to where it needs to go can be a real challenge. And Lucy talked about that as well. So, there are a number of things, number of strategies that can be put into place, but there has to be both the logistical apparatus as well as the funding and, the interest from policymakers to make that happen.
Absolutely. And I think both of you kind of touched on like the broader subject of, really assessing what resources are available to that specific region, what the issues are, and really pinpoint and try to figure out a way to, come together and work on those issues as well. So thank you both for those answers. We have another question here from Penny. And so she asks for the individuals who don't have access to a family doctor, such as refugees or undocumented individuals, what would be your best recommendation, I assume, for getting the shingles vaccine?
So, yeah, I'll take a shot at that. So, it is a real problem. And again, not just for shingles vaccines, but to healthcare access in general when it comes to these very specific populations. Even we don't even have to talk about people like refugees and undocumented people. There's a real shortage of family physicians across the board in many jurisdictions, even in Canada. So a few things to talk about. One is the availability outside of physicians' offices, as Lucy and I both mentioned before. Um, as well, the programs that are in place for refugees and undocumented people are there are gaps to be addressed within those programs. But the larger question is how do we provide healthcare in general as well as education around the availability of shingles vaccines and the necessity for vaccination. These are things that require not just education, but access to information as well. And if someone doesn't have access to the internet, let's say, because they belong to one of these populations, it's much more difficult to get that messaging directly to them. So there have to be ways imagined to consider how to get the information to people who have low access to information, in addition to low access to healthcare.
I would just say, I would just add that in every situation for any vaccination program, I would say the biggest issue, one of the factors that influences how a vaccination program is funded and whether it is funded is whether there's demand. And so without demand, and this is one of the factors, in addition to evidence and all these other cost benefit calculations that Dr. Lala was talking about, come into play when it comes to policy change. And so, yeah, so if you don't have the communication, as Dr. Lala just mentioned, to be able to reach the populations that should be vaccinated for shingles, then it becomes a bit of a vicious circle because policymakers won't want to go in an area and invest so much if there isn't a demand for it. So yeah, so that's all I wanted to add.
If I
Yeah,
could just add one more piece at a bigger picture level, we seem to be in a post-COVID era of misinformation as well. And so that adds an additional challenge. We're now seeing, for example, increase in cases of measles in the United States and Canada due to low vaccination rates. I was just looking at a poll today of how there's been an increase in the last 5 years of parental belief in childhood vaccination went up from 25% to about 39%. So these are all challenges that we have to now deal with in this new world that we live in as well.
Yeah, absolutely. It's definitely something to consider nowadays as well. Thank you both for those answers. We got two more questions in the chat here. I have a question here from Anjali. What could be the reasons for the Canadian government? We can maybe even extend this to a global audience, any other countries' governments, to not have uniform programs on shingles vaccinations? Is it because of a lack of evidence? But, is it on the advocacy front of things? Even though, we see the data of like how much of a burden that shingles poses on our healthcare systems, what are some of your thoughts on why we don't really have these uniform programs across the world?
It's a bit of a complicated response, but I'll try to distill it as best as I can. In Canada in particular, the reason why we don't have uniform programs across the country is mainly the way public health is jurisdictionally divided. So that's one of the issues. So every jurisdiction develops its own vaccination programs based on epidemiological data, cost benefit analysis from that epi data. So all of that comes into play. And also, the willingness of the population to be vaccinated. So these are all questions. And if you look at some of the NACI statements, which are really good examples of doing this population level analysis in the more recent years, is that they also consider the ethical and equity issues that come into play. So all of these components affect whether vaccines are available equally in this country. And there are other reasons. I'll let Dr. Lala talk about that as well.
Yeah, I think Lucy hit on the main point there. Something to consider. I mean, first of all, the science is the science. We can set aside the potential and philosophical issues around how studies are designed, et cetera, et cetera. But aside from that, something to remember is that funding of healthcare, each piece of it comes with an opportunity cost. And different jurisdictions have different priorities in terms of what they feel need to be funded from a limited pot of resources. So while shingles vaccines are absolutely important, especially for the elderly, there are many other things that are also important for the communities that have jurisdiction over how the funding pie gets split up. So that's one piece of it. When it comes to international advocacy as well, there also probably is a role for third-party groups to provide funding, whether it's things like the Gates Foundation or otherwise that provide funding for vaccination in developing countries. So there have to be a variety of different funding opportunities when it comes to these kinds of things.
Absolutely. Great answers, and a lot to consider just at the national level here in Canada, but also internationally. There's so many pieces of the puzzle to take into consideration when trying to understand why exactly it's not being prioritized, or at the moment being prioritized. So we are approaching our 10 a.m. mark here in Toronto, so close to near the end of our webinar today. But there is one more question I'm hoping if you guys can just very, very lightly touch on. And so I guess I'll just kind of reword it. So I guess what would be the best approach for initiating contact between, health authorities, public health departments, in enhancing the infrastructure for adult immunization, which includes shingles vaccination?
Okay, that's an excellent question. And it's one that's baffled me for many, many years. So there are many different FPTs, or federal, provincial, territorial committees that exist. I mentioned NACI. NACI is one of them. There is the Canadian Immunization Committee, which is also another one, and there's the Public Health Network. So it's a federal committee that has every chief medical officer of health, including their deputy ministers of health, that are on this particular committee, and they relate and discuss. So they call them interprovincial, interdepartmental organizations, or committees, I should say. And then more locally, there are many other different interprovincial or interjurisdictional committees that exist, where you have nursing groups that talk about health promotion. They talk about protocols, directives that are respective of regional authorities. And then the big issue is always data collection, right? So how do we share that information If there are cases, outbreaks, epidemics, how do we report those? And so we have infrastructure in place for centralized data collection and sharing. The issue with interjurisdictional sharing is probably the biggest problem we're having in Canada. And this is where, when we come to have or try to have, you know, a big picture of what vaccination coverage looks like in Canada, where we struggle, because every jurisdiction, as I said before, not only manages their own vaccination program and policies, but they also manage the types of data systems that they have. And most of the time, they are not interoperable with other jurisdictions, which makes it very difficult when it comes to coordination. And so just by giving you a bit of that information, you can tell the different layers that exist that make it difficult to communicate between, even sometimes between a healthcare provider and other healthcare providers in their own jurisdiction. And I know Dr. Lella has a lot to say about that, because that's a big issue. So I'll stop there.
Yeah, I mean, just with the limited time that I have, I don't have a lot to add to that, but just to say that, as Lucy mentioned, there are a lot of infrastructure components already in place. Uh, as she said, the bigger issue, I think, is not just interagency communication, but communication of information between healthcare professionals and policymakers, healthcare professionals and patients, individuals who need these vaccinations, who can also sometimes advocate for themselves when it comes to contacting their policymakers in their local jurisdictions. So, I think the messaging, the communication, we're in an age now of internet and artificial intelligence where there could be larger steps taken to help facilitate that transfer of information. But I think we'll see a lot more of that coming, especially with things like the Shingles Atlas.
Absolutely. So I just want to, now that we're at the end of our session, I would like to thank both of our speakers so much today for some incredibly insightful presentations, answering a lot of questions surrounding shingles vaccination, advocacy work. It truly is getting us thinking, in our respective regions, and hopefully it'll inspire some, movement, some action in these areas of work. I would also like to thank our participants for joining us today, and hope that you guys were able to come away with some really important information and some tools to really use towards working towards these changes. And as of now, I would also like to formally announce that the IFA's Shingles Atlas for Adult Vaccination, or SAAV, is now live. It is available for use, and we intend for it to be very useful in advocacy and policy work for shingles vaccination with adults. So thank you so much for your time, and please enjoy the rest of your day. Thank you so much.